Sure. Good afternoon, everyone. Today, my case presentation is on a patient, Salman Ahmed. He is 30-year-old male. He is Muslim, unmarried, studied till class 11, and used to work in a mobile shop, but unemployed for last 2 years. He is a resident of Dehradun and belonging to lower middle class socioeconomic status. The informant is a proband himself and mother, whose name is Shakila, 50-year-old female, not formally educated, homemaker, and stayed with the patient throughout the illness. Chief complaints are repetitive, intrusive thoughts, repetitive, intrusive acts for 5 years, low mood, increased frequency of crying spells, irritability, suicidal thoughts, and suspiciousness for last 2 years. The history given is clear, consistent, coherent, given a chronological order, corroborated among both the informants, and inadequate in terms of past treatment history. No predisposing or precipitating factors could be assessed. History of present illness. Patient was apparently well 7 years back when he was doing a course of mobile repairing and had started his own shop. After 2 years, he noticed that he was suffering from financial losses in his work because he was having difficulty in purchasing and selling items, not being able to decide what amount of items have to be purchased or sold at what amount. He would also be unable to do transactions with the clients, and he would also have difficulty in repairing mobile, because of which he shut off his repairing occupation and was only selling mobiles. As he would not be able to concentrate on his work, he would have repetitive thoughts while locking his shop, shocked that whether it is locked or not. These thoughts would occur daily while locking his shop and would be distressing to him. He would return back from home sometimes 2 to 3 times in the night to check his log. He would not be able to resist these thoughts, and whenever he would try to resist doing that, he would report of ghabrahat and fearfulness, feeling that something bad will happen and someone will rob his shop if he will not check. Whenever he would use a gas stove, he would come back from his room to check whether it's on or off. This would occur 4 to 5 times in a day. After which he would feel relaxed and would be able to sit at one place. He would clean the sofa whenever he would sit at one place because of the thoughts of dirt at everywhere he would see. Whenever he would wear clothes, he would have ghabrahat, because of which he would repeatedly wear or remove the clothes. This would occur 8 to 10 times in a day after taking bath. He would bath for normally 5 to 10 minutes, like usual. His family members noticed that whenever he would go to wash his hands, he would keep washing them for 10 to 15 minutes. And after closing the tap, whenever he would be about to go back, he would again come back and wash his hands and would continue to do so for 2 hours. He would also repeatedly wash his mouth to an extent that he would finish the water in the filter. During this time, he would have difficulty in onset of sleep, and because of the repetitive thoughts, he would sleep for not more than 4 to 5 hours in night and would wake up late in the morning. He would ask for meals by himself and would make tea for himself and would interact with family members as usual. 3 years back, as reported by the patient, he had a thought of drinking a poison, and he drank a bottle of poison, but after that, no complications were reported by the patient. For last 2 years, patients started reporting that people around him are talking about him, and whenever someone would be joking, he would feel that they were doing it about him. For last 1 year, he would get angry at small matters whenever his father would scold him uh, for not being able to work. He once even broke his keyboard angrily, but never physically abused anyone in his family members. He would feel low most of the time on most days and would be seen sitting in his shop most of the time and not being able to work, and would not feel pleasurable in previously pleasurable activities like playing or interacting with family members. He would like he would get easily fatigued even after doing small work and would be laying in bed most of the time on most days. He would forget minor things and difficulty to remember those things. He also reported of suicidal thoughts that he would think of drinking poison, but these thoughts would not be distressing to him, and he would feel like doing self-harm, but never, there is no history of committing such acts. He was on continuous medications for 5 years, but as reported by the patient and attendants, there has been no improvement or minimal improvement in the complaints. Patient also reports the history of repetitive crime spells whenever he would feel that he is not able to perform work as earlier he used to do. During this time, he is reporting of disturbed sleep, normal appetite, and bowel and bladder habits were normal. In negative history, there is no history of persistent, pervasive, elevated mood over familiarity, increased psychomotor activity. There is no history of thoughts being known to others, thoughts being heard aloud, or inserted or inserted into or taken out from an external agency. There is no history of breaks and interpolations of thought. There is no history suggestive of catatonic behavior, such as excitement or posturing. There is no history of loss of consciousness, uprolling of eyeballs, or abnormal body movements, frothing of mouth. Past treatment history. Past treatment records are not available and family history. He is third in order out of three siblings. Demise of father 3 years back in COVID. Demise of brother 2 years back in renal failure. No significant psychiatric history in family. Significant medical history of in mother. She's a known case of hypertension on medications. Emotional head of the family is mother, and financial head is the patient. Personal history. There is no history of tobacco intake in the past. Currently, he is abstinent. Childhood history. Childhood history, normal vaginal delivery at home by DAI. Developmental milestones were achieved as per age. No history of fever, cyanosis, no history of NICU admission, and immunized as per the parent. Childhood history, started going to school at 5 years of age. He would participate in co-curricular activities. He would easily make friends and had long-term friends. Would share toys with siblings and friends. Scholastic history, average. He was an average student. In 10th class, he achieved second division and failed 11th class. And on repetition, he passed. But after that, he failed 12th class also. Pre-morbid personality, was ambitious and wanted to enter in army and also gave army exams. He would be shy and would take long time to make friends. He would enjoy playing cricket with friends and would even play video games. He would keep all the items in its place and would be orderly and keep the surroundings clean. He would obey laws and had normal sleep-wake cycle. So, according to the pre-morbid personality, he had well-adjusted personality and no history of anancastic traits. Physical examination, weight was 96 kg, height 162 centimeters. So 5 years.
Self-harm attempt 3 years back.
Yes.
So what was the intent?
So it was because of the obsessive thoughts that I would drink this poison, and after that he drank. But there was no intentions of self-harming. But currently he's reporting that he is having suicidal thoughts, that he's not able to work and do daily living activities.
Eventually, he wanted to kill himself.
No, it was a repetitive thought that I will drink, and after that he drank the poison. So physical examination, weight is 96 kg, height 162 centimeter, BMI 36.6 kg per meter square. He's endomorphic male, black nevus on the right side of face of 5 centimeter near the outer cancers of the right eye. Pulse is 86 per meter on sitting, and the BP was 110/80 on sitting position. Uh, On CVS examination, S1, S2 was present. Heart rate was 86 per minute. Respiratory rate, bilateral air entry was present. Breath sounds were present. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema was absent. On abdominal examination, on inspection, no scar marks were seen, and no organomegaly bole sounds were present. Nervous system, so I was able to do olfactory, optic, oculomotor, trigeminal, facial, vestibulocochlear, hypoglossal examination, and this was intact. Superficial reflexes, I was able to do corneal reflex, which was normal. In sensory, that in both right and left limbs. In motor system, tone was normal in right and left extremities, and bulk was normal, power was 5/5. Cerebral signs were intact. On MSc, endomorphic built male entered the room unaided, accompanied with mother, sat on the chair provided, returned the greetings of the interviewer, wearing a shirt and trousers as appropriate for surroundings and weather. Hair are combed and trimmed, shaved beard, kempt and tidy, with adequate hygiene. Eye contact was initiated but fleeting and in touch with the surroundings. Attitude was evasive. Manner of relating was anxious, and subsequently during the interview, he appeared confused. A rapport was established with difficulty. Speech was soft, monotonous. Intensity was decreased. Reaction time was increased. Clear, coherent, and goal directed. Psychomotor activity was decreased. Mood ठीक है. Affect was depressed with restricted range and reactivity. It was communicable, congruent, and appropriate. Cognitive functions, he was oriented to he was able to do digit subtraction 100 minus 7 and was able to repeat days of the week backwards. Memory, his recent was intact. He was able to tell what he ate yesterday at night, and remote was also intact. He was able to tell when he went to school or which age he went to school and his father's marriage anniversary. New learning ability was intact. He was able to repeat the 3 words I asked him at 5, 10, 30 minutes. The intelligent general fund of information was intact. Who is the Prime Minister of India, CM of Dehradun, and function of lungs, he was able to tell. Ability, abstract ability, he was able to tell 2 similarities between apple and banana. So abstract ability was intact. Thought flow, there was poverty of speech. Form, no formal thought disorder. Content, ideas of persecution and reference were present. ऐसा लगता है कि मेरे बारे में बात करते हैं, मजाक बनाते हैं मेरा लोग और मुझे मारना चाहते हैं, पर ये मेरा वहम भी हो सकता है. And ideas of worthlessness and hopelessness were also present. Ideas of hopelessness and worthlessness were also present. ये possession नहीं आता.
2 चीजें फिश और
अलग है. कैप्लन में उसमें आता है.
फिश को फॉलो करेंगे तो
Possession. Possession, repetitive obsessive thoughts and compulsive acts. Perception, none. Judgment, personal, social, and test was intact. Insight was grade 4. He was able to tell that all the symptoms are because of a mental illness, and he's able to, and he's agreeing that he has to take treatment for that.
why not?
5, because he's referring that the illness is because of his condition, his internal source, because of this 4. 5th is intellectual insight.
What you described, it more like, what makes it right? One is complete denial. One is denying and
Denying.
accepting. He is
External
accepting
source.
some external.
4 is
He applying
internal.
to something unknown in self, but not accepting it as a
5.
which is also
5. Intellectual.
inside grade 4 में patient will refer it to the reason something unknown in self, but not refer it as a mental illness. है ना सर, यही होगा. अगर वो mental illness को accept कर रहा है कि हाँ मुझे mental illness है और मुझे दवाई की जरूरत है, तो 5 नहीं आएगा.
यूजुअली हम सिर्फ ये कॉजेलिटी पे जाते हैं, मतलब मेंटल इलनेस है या नहीं है ये तो मेरे को नहीं याद, हम लोग जाते हैं कॉजेलिटी पे जाते हैं कि कॉजेलिटी क्या है, उसके साथ उसको वो मतलब कुछ साइकोपैथोलॉजी समझ रहे हैं, उसको बहुत समझ रहे हैं, समझ में इट्स बायोलॉजिकल मतलब
ये नहीं पता उसे बायोलॉजिकल इलनेस के बारे में, बट इलनेस का पता है देयर इज
जैसे वो कहते हैं ना, 4 क्वेश्चंस होते हैं उसी ऑर्डर में
हाँ
पूछते हैं।
वो पूछे थे।
क्या क्या पूछा था और क्या क्या जवाब।
आपको लगता है कि ये बीमारी आपके किसी ये बीमारी अलग है, फिर उसके बाद ये बीमारी किसी अ, ये बीमारी लक्षण जो है बीमारी के ये दिमागी परेशानी के हैं और इन दिमागी परेशानी के लिए ट्रीटमेंट जरूरी है और ट्रीटमेंट लेना चाहेंगे इसके लिए।
क्या क्या जवाब।
तो ये बीमारी है उसे पता, फिर ये मेंटल इलनेस है ये भी उसे पता है, फिर इसके लिए वो ट्रीटमेंट लेना चाहता है ये भी पता है।
तो सर उसे जैसे क्या ये आपको लगता है कि आपको कोई बीमारी है? हाँ। आपको लगता है ये लक्षण किसी दिमागी बीमारी के हैं? तो भी हाँ। आपको इलाज लेने की जरूरत है? क्या इलाज से ठीक होगा? हाँ। तो उसे ग्रेड 5 में जाता है।
ग्रेड 5 ग्रेड 5
but why it is 4 and not 5?
So I was thinking that this is because he is referring that the illness is because of something wrong in him. So he was referring as internal.
इलनेस क्यों हुई ये क्वेश्चन
Illness क्यों?
he is saying there is an illness and it's a mental health illness.
And he is agreeing to take treatment for this.
बड़ी नहीं है, आपके 4 क्वेश्चंस क्या क्या हैं?
सर क्या आपको लगता है कि आपको कोई बीमारी है?
हाँ।
क्या ये बीमारी लक्षण बीमारी के दिमागी परेशानी के हैं?
हाँ।
और क्या इस दिमागी परेशानी के लिए आप ट्रीटमेंट लेंगे और क्या आप कंटिन्यूसली ट्रीटमेंट लेंगे?
Get more information. Document 1, 4 and 5. Since inside is there, but document 1 exactly 4 and 5 how
4
much
and-
understand about illness? कितनी उसकी knowledge है, कितने मतलब why क्यों treatment क्यों लेगा? This is illness, then only we can ask more. ये तो प्रयत्न करना पड़ेगा कि मतलब बीमारी क्या है,
क्या
आपको
है?
पता है कैसे हुई है? Not necessarily you should tell that in your hospital, but you should tell कि ठीक है brain में कुछ chemical problem है, उस वजह से ये हुआ है, ऐसा नहीं कि फिर वो बात है, then only you can comment on it. एक क्वेश्चन तो फॉलो क्वेश्चन तो होगा ही.
Index patient Mr. Salman Ahmed, a 30-year-old unmarried Muslim male, third in order out of 3 siblings, studied class 11, failed class 12, worked in a shop, currently unemployed for 2 years, resident of Dehradun, belonging to lower middle class socioeconomic status, with history of demise of father 3 years back, history of demise of brother 2 years back because of renal failure, history of hypertension in mother, with no significant past medical history, presented to OPD with complaints that are insidious in onset, continuous and deteriorating course. The history given is reliable and but inadequate in terms of past treatment history. Chief complaints are repetitive intrusive thoughts, repetitive acts for 5 years, low mood, increased frequency of crying spells, irritability, suicidal thoughts, and suspiciousness for last 2 years. He's gross normally general physical examination grossly within normal limits, and on MSc, his attitude was evasive. His rapport in thought content, ideas of persecution, and ideas of reference were present with ideas of hopelessness and worthlessness. In possession, repetitive obsessive thoughts and acts were present. So he's kept on a provisional diagnosis of mixed obsessive compulsive act with severe depressive disorder with psychotic symptoms.
With?
Psychotic symptoms.
ये बोलो 5
So points in favor of my diagnosis because it started as repetitive thoughts. He started to have repetitive thoughts and acts, and since last 2 years, he is reporting of low mood and all the criteria of depression have been fulfilled. Low mood, decreased frequency of crying, increased frequency of crying spells, easy fatigability, and inability to concentrate and work, and suicidal thoughts he's also reporting. With suspiciousness that ideas of persecution and reference are also present. But or other features of psychosis are not present. I could not evaluate. He was not telling any hallucinatory behavior or
वो तो आपने rule out कर लिया होगा नेगेटिव स्ट्रेन
yes.
सही क्या है क्वेश्चन से
If because of the ideas, then so they call it psychotic.
But suspiciousness is still present. The ideas like
ideas clear पे तो psychology anyway आपका ओसीडी का स्पेसिफाई है कुछ
so good insight.
आपने हैं
Good insight.
गुड इनसाइट है तो फिर उसने सेल्फ हार्म क्यों किया बट इन ओसीडी व्हाट इंप्लाइज गुड इनसाइट
That he is able to recognize the illness, that he is having the thoughts and repetitive acts, and they are distressing, and he is able to resist them.
ओसीडी इनसाइट में ये तो ना लिखा हुआ है कि बीमारी का पता है नहीं पता तो ओसीडी इनसाइट में तो जो स्पेसिफाई है उसमें तो कुछ और टर्म्स लिखी हुई है ना
Insight.
The OCD का specified insight means that doesn't mean he is understanding whether he is ill or not. It is about the thoughts that they are ego dystonic. I don't want to think that these thoughts are excessive and intrusive and they are of the waste and he acts on the thought as if they are natural thoughts.
So
OCD
they
insight
are
तो
ego dystonic and they are distressing to him.
they are distressing to him. And if it is clarified, then okay, that is good insight. But is he very clear the thoughts are his own? But
Yes, yes, sir. He is.
they are not necessary thoughts.
They are not.
They are
necessary.
persisting beyond a point. So these points बताने पड़ेंगे.
Yes, sir.
अगर मैंने feel you say the specify
Good insight.
good insight.
So it was not exactly a poison. He was telling that there was something in the bottle and then he drank it.
You also good insight without a reason.
But now he's reporting of suicidal thoughts that मन करता है कि poison पी लूं.
Whatever, go ahead.
Also,
Depression की severity क्या है?
severe depression with psychotic.
ठीक है और दूसरा डाउट
Independent diagnosis of severe depression, secondary diagnosis of depression. Should they make one diagnosis of obsessive compulsive disorder?
आप क्या चाहेंगे कैसे secondary for the बात you have to make as much diagnosis as possible given their criteria secondary And अभी डिप्रेशन है, कुछ भी हो सकता है। अब डिप्रेशन की वजह से कोई अल्कोहल नहीं लग जाए, ये थोड़ा अल्कोहल डिपेंडेंस हो जाए, अल्कोहल डिपेंडेंस से बनाना पड़ेगा। हम जैसे अल्कोहलिक लिवर डिजीज है, वो अल्कोहल की वजह से टेस्ट करेंगे लिवर डिजीज में, लिवर डिजीज तो है, अल्कोहल डिपेंडेंस अल्कोहलिक लिवर डिजीज। और तो वैसे narcotic is not psychosis, not independent psychosis.
So because no history of no relevant history suggesting psychosis was assessed, could be assessed. There was no history of hallucinatory behavior, self-muttering, or behavior.
Psychosis तो इन सबके बिना भी हो सकता है, psychosis तो आप कह ही रहे हैं कि psychotic है। Psychosis तो मतलब अगर आपका hallucinate नहीं है तब भी हो ही सकता है, कि अगर behavior disturbance नहीं है।
But
But why this is depression and psychosis are not independent psychosis? This depression is independent here. Psychosis is independent.
But so in psychosis, patient will not tell that he is feeling low or he is having repetitive.
Psychotic patient बहुत सारे patient बता देते हैं, even in active psychosis they can tell कि मेरा definitely not.
Um,
बोलो बोलो।
So the criteria of depression was met.
Okay. डिप्रेशन तो है, लेकिन साइकोसिस इंडिपेंडेंट है, डिप्रेशन विद साइकोसिस है, कैसे डिफरेंस है? इतना डिफिकल्ट नहीं है, तो डिप्रेशन पहले आया और डिप्रेशन कंटिन्यूस था, टेम्पोरल रिलेशनशिप है, डिप्रेशन कॉन्सेप्ट साइकोसिस सिम्टम कॉन्सेप्ट डिप्रेशन के बाद में, देन यू कैन कमेंट अपॉन थीम कि जो थीम है वो ऐसी है कि डिप्रेसिव है, वो आपको क्या उसका होता सस्पेशंस क्यों है, व्हाई डज ही थिंक दैट पीपल मे हार्म हिम बिकॉज़ ही इज समथिंग दैट ही मस्ट बी।
वो इंटरव्यू में इतना वो mood comment. So he was not able to justify why everyone is talking about him. Information.
Concept of some psychotic symptom within a depressive symptom are usually part of considered depression disorder. और आप मतलब अभी सुसाइडल बेसिस में कुछ अलग डायग्नोसिस बनाएंगे?
So itni extreme suicidal thoughts nahi hai, but he is reporting that sometimes he feels that he should drink something, but no planning or intent is present.
कैसे evaluate करते हैं planning करेंगे?
He has never planned that I will do this to harm himself or.
What is better attempt?
So incomplete.
When will you call it a suicidal attempt?
So the intent was to die. So it was lethal.
इतना जरूरी नहीं है attempt भी होना चाहिए, and attempt to die, wish to die, and any kind of self harm is considered unconsensual. Then there are further attempts, aborted attempt, infected attempt. अगर स्क्रैच करा
So whether the intent was to die or was it out of impulsive?
after mixed dose
Mixed dose.
treatment history में आपने क्या बताया?
So past treatment history is not there.
But you need some information ना हमें treatment history plan करने के लिए कितना time medication खाई dose change
So
हुई
since 5 years he is on medication.
he's on regular medication
He's on regular
Compliance आपने check
medication.
किया
He's compliant to medications, but he's reporting minimal improvement on medication.
कितना और मेडिकेशन कितने थी कौन सा ग्रुप की थी किससे ली साइकियाट्रिस्ट ली किससे ली
So psychiatrist से चल रही थी, लेकिन treatment records available नहीं है.
बिल्कुल भी नहीं है कुछ आपको थोड़ा सा हिंट देना पड़ेगा कि ऐसी दवाई थी क्या कुछ जो नाम भी ले सकते हो कभी तभी तो ट्रीटमेंट आगे प्लान करेंगे उसने कोई इन्फॉर्मेशन नहीं दे पाई क्या medicine,
नहीं,
लेकिन रेगुलर मेडिसिन
regular. So बीच में on and off थी medications की, कभी-कभी छूट जाती थी, but otherwise he was on.
देन यू लेट मी टू आस्क मैक्सिमम कितना टाइम बिना रुके रेगुलर खाएगा
Mm.
which can consider whether it's a resistant OCD or not. ठीक है मैनेजमेंट बताइए आप क्या करें
So I will admit the patient because of this severe social and occupational dysfunction as reported by the patient in disturbed sleep under the section 86 of Mental Health Care Act, and I will evaluate the patient and I will do subsequent MSCs. I will apply scales for the after evaluation. I will send normal routine investigations of CBC, LFT, KFT, ECG will be done, and RBS. And I will start the patient on antidepressant, SSRIs, and along with antipsychotics of first generation, preferably because of the metabolic side effects, and he is an endomorphic built male.
yes
So fluoxetine is preferred in OC with depression.
but there's a history of lack of response with 5 year of treatment
So then clomipramine is considered in refractory cases as well as with antipsychotics, risperidone and aripiprazole.
so after मुझे कुछ नहीं देनी Oxygen with Haliburton.
So first the treatment evaluation will be done, past treatment responses will be checked, and after
reports and
so they have records, but they are in their own in
the management of the party will ask them to fetch the remote
their records.
refractory OCD definition
No response on two trials of antidepressants for a period of 6 weeks.
there's some schizophrenia almost refractory OCD.
For 2 weeks.
Sangeeta, adequate time to plan this.
OCD में trial is longer कम नहीं है
Well-
antipsychotic के trial ज़्यादा है so that's why it is important to ask if treatment compliance अच्छा time है अगर treatment compliance है and then you will start clomipramine again waiting कर सकती है but फिर भी effective होना ही पड़ेगा लेकिन तब तक मैं पता ही कि trial adequate हुआ है कैसे आगे so even if you don't have any history of reports but you need to ask the level कितना time maximum दिया था because you need to ask them think कि मतलब अगर adequate डाल दो ऐसे तो ही होगा तो मैं ऐसे तो मतलब actually ओसीडी के लिए शायद एक ड्रग चाहिए, एक एक्सरसाइज चाहिए, क्योंकि ऑप्शन ही नहीं है दूसरी। एक एक्सरसाइज तो है आपके पास,
हाँ,
एक्सरसाइज चाहिए, अभी जस्ट चेक इट फर्स्ट for 12 weeks.
first line is CBT or SSRI after 12 weeks. If there is no response, then it's refractory.
चेक करना ना, दो नहीं चाहिए, ज्यादा एक्सरसाइज नहीं करना, बट फर्स्ट एक्सरसाइज के बाद अगर लैक ऑफ रिस्पॉन्स है, देन दे कंसीडर एडिंग CBD, then
Yes.
if lack of
Second.
then this error from the
Yes, sir.
and then there's an adequate trial of exercise, and you can straight away start from more time to rest training. Or doses be adequate CNV. Then we need to know the doses क्या है.
I will check.
Which antipsychotics are used as adjuvant in OCD?
So risperidone, aripiprazole. These two are recommended. So these two are recommended, but considering
चलो ठीक है, आप लोग का यूज़ करो, ठीक है? चलो बाकी